do is review the list of tools that we have available for pre-season testing at this time, and then recognize the essential components and tools that we have available for the sideline evaluation and management of concussion. And then finally, review the in-office evaluation of concussion, including the most important decision, which is returning to play and when that would be appropriate and when it's not. So every time we talk about a different setting, whether it be pre-season, the sideline, or the in-office, what I want to emphasize is what our goal is. The goal of the pre-season assessment is to determine what the baseline neurologic function of that individual is. We have various tools that we can use so that we can compare the baseline neurologic function to the post-injury neurologic function, including the symptom scale, standardization of concussion, which is a cognitive screen, balance assessment, the King-Debig test, as well as computerized neuropsychometric testing. So baseline graded symptom checklist is very important to do because we have found that both in adults as well as pediatric, 50 to 70% of individuals will have symptoms present at baseline. And this makes sense because these validated symptom checklists are listed 22 variety of symptoms that are most common in the setting of concussion. And a lot of these are very non-specific. Headache, drowsiness, difficulty concentrating. It's important to have a baseline checklist and score so that that serves as your goal for the recovery phase. In addition, on the left-hand side of the screen, this is a standardized assessment of concussion. It's a cognitive screen that looks at orientation, memory, concentration, as well as delayed recall. And then on the right is the balance examination, which typically will include either the balance error scoring system or time-tandem gait. Both Dr. Sunny and Dr. Vogel will review these tests in more detail. The King-Debig test is a rapid number naming test that captures abnormal eye movements, language, as well as attention deficits. So eye movement deficiency is a very sensitive measure of brain dysfunction. We use greater than 50% of our brain networks and circuits to coordinate our eye movements. And so in injuries that result in diffuse brain dysfunction, such as concussion, the King-Debig test, which is evaluating eye movement efficiency, is very, very sensitive. What is important is that for this test to be used as a remove from play tool on the sideline, we must have a baseline. In fact, we have to have a yearly baseline because eye movement efficiency can change over years, especially based on brain development in our pediatric population. So the way that this test is completed is that there's a series of 3 screens. We do it on a tablet. There's a series of 3 screens, and the individual is reading the numbers from left to right, all the way down to the bottom of the screen. And as you can see, the screens get progressively harder, where the lines go away and the numbers get closer together, resulting in visual crowding. The way that we perform the baseline is the individual reads screen 1, 2, and 3. They have a cumulative time. They have to complete it twice with no errors, and the fastest time is going to be that individual's baseline King-Debig test time, their baseline function of eye movement efficiency. In addition, another tool that we use pre-season is computerized neuropsychometric testing, which Dr. Wethy will go through in more detail. So now let's go ahead and talk about the sideline evaluation. And again, as promised, let's talk about the goal of the sideline evaluation. The goal of the sideline evaluation, the most important part, is to remove an individual from play when appropriate, to prevent re-injury. Data has demonstrated that a second concussion occurs within those first 7 to 10 days after the initial concussion. So 90% of the time, the second concussion an individual has occurs within the first 7 to 10 days. And that's why it's so important that we identify individuals that are suffering from a concussion immediately and remove them from play. That is the goal of the sideline evaluation. However, the other component that sideline evaluation tools must have is not only do they have to be accurate and reliable, they also have to be easy to administer, they need to be rapid, and they need to be accessible and administered by many individuals, whether they be healthcare professionals or maybe even if no healthcare professional is available on the sideline, something that can be administered by other individuals. So the sideline evaluation tools are similar to what you already have for obtaining the neurologic baseline function. symptom checklist in this setting, I'm cycling again because it needs to be rapid. Instead of having them scale it from 0 to 6, we usually just ask them yes or no. Do you have a headache? Are you busy? Are you having difficulty concentrating? Are you having difficulty tolerating the light, etc.? If there is a healthcare professional that is on the sideline that is trained in concussion management, we will have them administer the standardized assessment of concussion, a balance assessment, which would either be the balance or scoring system or the time tandem gait, as well as the King-Dievig test. The 4 top tools are all consolidated into the Sports Concussion Assessment Tool, or the SCAT-3. And then the King-Dievig test is a tablet test that we administer. For the post-injury King-Dievig test, they will take the test and have one slide. And in that slide, their post-injury KD time is then compared back to their baseline KD time. And if the baseline KD time, or the post-injury KD time, is prolonged by 1 second or more, that individual is removed from play. Now, you might think, well, 1 second, that seems to be a very, very small window. However, what we've also demonstrated by looking at the King-Dievig test in a game time situation or in an exercise situation is not only is this test does not have fatigability, but actually in a game time situation or in a setting of exercise, individuals typically perform better than their baseline, probably because of the adrenaline, etc. However, in a post-injury setting, if someone is 1 second or longer, that is concerning that there might be some sort of brain dysfunction that is occurring. Again, this is a tool, and it is a screening tool. In addition, if there are any uncorrected errors that were made during a post-injury KD test, we recommend that athlete should undergo additional evaluation and potentially be removed from play. Now, none of these tools that I've given you have 100% accuracy, 100% sensitivity or specificity, but what we have found in data is that if you combine the tools, so multimodal assessment, then you can actually start reaching 100% sensitivity and specificity. What you see here on this side is these are RSC cards looking at individual tests. The green is the standard assessment of concussion, the cognitive training. The red is the King-Dievig test, the rapid eye movement test or eye movement efficiency test. And then the blue, which is the tandem gait. On your x-axis is 1 minus specificity, and on your y-axis is sensitivity. And as you see, when you combine the assessments over here, the red line combines the standardized assessment of concussion, the KD, as well as time tandem gait, you can near 100% sensitivity and specificity. So right now we know multimodal assessments are the way to go. On this slide, I've ordered things from the lowest sensitivity and specificity to the highest. And again, stressing that multimodal assessments are the best tools that we have available at this time. Now let's focus on the outpatient evaluation of concussion. And the most important part of an outpatient evaluation of concussion is that we must prioritize these patients. So if you're seeing individuals with concussion in your practice, try to set aside a couple of appointment times for those individuals. It's so important that we see these individuals within 24 to 72 hours of them having the concussion. And why? The reason is because number 1, you have to manage their symptoms, and number 2, you want to prevent premature return to learn and return to play, which could potentially worsen or exacerbate their symptoms. So appropriate management, you need to prioritize their evaluation. And then you can limit their symptom exacerbation and then prevent premature return to learn and return to play. Now, in an initial visit, there are several key components. Of course, you want to get the date of the injury so that you can follow them over time, their post-injury day, as well as details regarding the injury itself. So the mechanism of injury, the location of impact, if there was actually direct contact to the head or not, or if there was whiplash injury, and then also the duration of loss of consciousness, if it was present at all, and the duration of amnesia, if that was present at all. The other important thing is that you want to obtain both immediate and delayed symptoms. Really, you want to develop the timeline of what occurred, the progression of symptoms from the time of the head injury to the point where they come to see you at the visit. Because there are many symptoms that worsen over time. It's kind of like working out, where you're sore the second or third day the most. The similar thing seems to happen in concussion, when usually the second or third day after the injury is when people are most symptomatic, and then typically it'll either stabilize that point on. Now, the symptoms of a concussion fall in several different domains: physical, cognitive, emotional, and sleep. The most common symptoms that are reported, of course, are headache and dizziness. And we healthcare providers really focus on the headache and the dizziness. But sometimes we forget to address the emotional and the sleep symptoms, which is unfortunate because oftentimes the emotional and the sleep symptoms are the ones that are scariest for patients as well as for their caregivers or parents, and they can also be the most problematic. So it is important to address each domain, including the emotional and the sleep domain. Typically, in our evaluations, we will have them complete a graded symptom checklist, which goes over those 22 most common symptoms and grades them from a scale of 0 to 6. And then we can monitor this over time through their recovery. And if you have that baseline symptom checklist, that ends up being your goal. The other thing that is important to obtain during that initial visit is risk factors for prolonged recovery, which is key because that will provide you with the education and information you need as a healthcare provider to educate the patient and the family about the prognosis of the trajectory of recovery. So these include obtaining a pre-injury history of headache, because we know from data and observational data that having a prior history of migraine can predispose you to having a longer recovery after the injury. In addition, even if the individual doesn't have a history of migraine, if there's a family history of migraine, that somehow the genetics of that predisposes that individual to having a prolonged recovery. In addition, if there's a history of learning disabilities, ADD, ADHD, dyslexia, or psychiatric histories such as depression or anxiety, these are all risk factors for prolonged recovery after the concussion. You also want to obtain a detailed concussion history, because number one, once you've had one concussion, you're more likely to have another, and know that potentially their recovery could be longer. So not only do you want to find out how many concussions someone has had in the past, but also the symptom duration. And the other important thing is you want to determine if there is a history of reduced threshold. So what that means is if the individuals have multiple concussions, if now less and less mechanical impact is resulting in a concussion or more and more severe symptoms. If there's evidence of a reduced threshold, that's concerning and oftentimes is a red flag for us to start discussing retirement from high-risk contact sports. Now, headache is one of the most common symptoms after concussion. So let's focus a little bit on the headache. Number one, just like in your headache evaluation, you want to first screen for red flags. If an individual has intractable vomiting, changes in their level of awareness, worsening headache, or progressively worsening headache, where every day just keeps getting worse and worse and worse, that may be an indication that this individual needs more urgent neuroimaging. However, if no red flags are present, but they have this irritable headache, the other thing you want to do is obtain characteristics of the headache. And the reason that is important is this. Based on the International Classification of Headache Disorders, a post-traumatic headache is defined as a headache that occurs 7 days after the head injury. But there is no information regarding the characteristics of the headache to meet that diagnostic criteria. However, we don't have randomized controlled trials for post-traumatic headache that tell us what to use to treat these individuals. The way that we determine the treatment is we obtain the characteristics of this individual's post-traumatic headache. For example, if they have migraine features, then they would have a migraine phenotype in their post-traumatic headache, and we would treat them with migraine medication. Now, in the physical examination, I want to point out a couple key components. Number one, vitals are vital, even in the setting of concussion. One of the main reasons why it is so vital is because we want to obtain orthostatic heart rate and blood pressure. Because we find a lot of these individuals, after they've had a concussion, have autonomic instability, both in the heart rate as well as the blood pressure. And so you want to get orthostatic vitals, blood pressure and heart rate lying down flat, standing 1 minute, 5 minutes, and 10 minutes. And oftentimes you will see evidence of autonomic instability. In addition, in your HEENT examination as well as musculoskeletal examination, you may find abnormalities that will guide you as far as treatment for that individual patient, such as identifying trigger points or seeing evidence of BPPV with a positive complete a detailed neurological examination, starting with the mental status exam, and truly, in the in-office setting, you can use your validated tools that you have. Oftentimes in the return to play clinic and the concussion clinic, I do use the standard assessment of concussion, which has actually been validated on the sideline. The reason I like to use it in the office is because it's a common language that I can speak with the athletic trainers and the other individuals that are involved in their sports medical care. Now, a cranial nerve examination is important, and I've listed here various abnormalities that can be present in the different cranial nerve examinations. However, I want to focus on the extraocular movements. The extraocular movements are very sensitive in being affected after a concussion. Dr. Vogel will discuss the details of the oculomotor lesion, as well as I mentioned before, looking at eye movement efficiency with the King-David test. The rest of your neurologic examination, you really should be looking for subtle upper motor neuron signs. So looking for a pronator drift, looking for a fixed arm when you're doing a forearm roll or finger roll, and then of course doing a balance assessment as well. And then remember the things that are available in your concussion toolbox. You have the King-David test to look for eye movement efficiency. You have neuropsychological testing, whether they be the computerized testing or gold standard paper and pencil testing, objective vestibular testing, autonomic testing, if that's available in your institution, and then also neuroimaging, if that's indicated. Now let's talk a little bit about neuroimaging. When should you get a CT scan of the head? The only time a CT scan of the head is truly helpful is if you're suspicious there might be a skull fracture or intracranial bleeding. Otherwise, a CT scan of the head does nothing for you. It doesn't rule anything in, it doesn't rule anything out, except the skull fracture and intracranial bleeding. However, an MRI of the brain can be useful, especially with advanced imaging techniques, including susceptibility weighted imaging, diffusion tensor imaging, arterial spin labeling, and spectroscopy. These tests can give you specific details regarding the structure and function of the brain. Susceptibility weighted imaging will tell you about tiny areas of hematuria deposition, which can occur in severe injury during a diffuse axonal injury. And the same information you can get from diffusion tensor imaging about the integrity of the white matter tracts. And then also functional details in arterial spin labeling from perfusion abnormalities, and then normal vitality with MR spectroscopy. Now let's talk about the management of concussion. The goal of management of concussion is twofold. One is provide symptomatic treatment. Just because the majority of these patients will get better on their own, doesn't mean that they need to suffer during the time they're getting better. You want to provide symptomatic treatment while they're feeling terrible. In addition, you want to prevent re-injury while the brain is still healing. So here's a case. This is Lexi. She's a 19-year-old collegiate soccer player. She was kicked in the head 13 days ago and diagnosed with a concussion by an athletic trainer. Since then, she has had no improvement in symptoms and thus was referred to our return to play clinic. I walk in, I sit down, and I say, Lexi, tell me what's going on. She says, I feel like I feel like I can't think I can't remember anything, I just feel awful. At which point she breaks in and shares an experience and I can't stop crying. Well, this is a very, very common presentation of many of our patients. And so what do we do for Lexi? Should we treat her headache? Should we treat her dizziness and her lightheadedness? How about her ocular abnormalities? Should we focus on her cognitive difficulties? Her insomnia? Or her emotional lability? The answer is if we only address one of these, she's not going to feel better. The reason it is so important to have a multidisciplinary approach to management of concussion is because multidisciplinary symptoms require a multidisciplinary approach. And so that is why in our concussion clinic, we have me as the neurologist, Dr. Westgate, and my psychologist, Dr. Vogel, as the behavioral neurologist, and then an entire team of individuals around us who can then, we go through a list of the various symptoms that an individual is having, and then we provide specific treatment for each of those individual abnormalities. Now let's focus on the headache, since I am a headache specialist, and it is the most common symptom after a concussion. Again, with the headache, you diagnose this post-traumatic headache, and then you determine the phenotype. The most common phenotype well as some nauseous. So what would we do to treat her headache? Number one, should we simply provide her reassurance that her headache will improve over time? And that's all? Number two, should we give her a triplet for acute relief? Number three, should we actually consider preventive medication for her, even though this is only 14 days later? Well, the answer could be either 2 or 3. The answer is not number one. And unfortunately, I still see patients today. They come to me a week, several weeks, even months after having a post-traumatic headache without ever receiving any type of symptomatic treatment from a healthcare provider because they're told, treatment is going to be in 7 days, don't worry about it. However, why should we treat post-traumatic headache? It's simple. We should treat it because it hurts. We should treat it because we can improve the pain and disability that people are suffering from because of their post-traumatic headache. And we also learn in a couple more slides that we need to integrate these individuals back into life, back into cognitive and physical activity, and it's harder to do that when they have a terrible headache. In addition, if you don't treat their headache, someone else will, or they'll learn how to treat it themselves. And this population is at high risk of developing medication overuse with over-the-counter medications because they need to get relief somehow. In addition, the expert consensus currently thinks that if we can address the acute post-traumatic headache, we can perhaps prevent the chronification and the transformation to persistent post-traumatic headache, which is a post-traumatic headache that lasts beyond 3 months after the injury. Now, what we are limited by, of course, is the lack of randomized controlled trials for the treatment of post-traumatic headache. But again, we can borrow from the migraine evidence if they have migraine phenotype. The systematic approach to treating post-traumatic headache is number one, you want to look for those red flags. Number two, identify that phenotype. Number three, elicit that prior history of headache. Because I'm going to say even starting a preventive medication for this patient might have been a good answer. What if when you're taking history, and you've taken a pre-injury history, this young girl tells me, you know what, even before I had the concussion, I used to have 1 to 2 headaches per week. That's just what I always had since I started my period a couple years ago. Well, that individual probably met criteria for prevention even before she had the concussion. So for that individual, I would consider starting prevention right away because she needs prevention for her underlying migraine disorder, and then that will help her recover from her post-traumatic headache as well. Also, you want to initiate acute treatment early and use migraine-specific treatment options if they have a migraine phenotype. You want to very carefully monitor for medication overuse and get a good history of what over-the-counter medications they're using because perhaps they needed something to just feel better. They don't realize that taking ibuprofen or Excedrin migraine on a daily basis can potentially worsen their headache disorder by developing medication overuse headache on top of the post-traumatic headache. And then consider that preventive treatment early, really within weeks, and also think about the comorbidities when you're choosing a preventive treatment option. For example, if someone has a very rapid heart rate because of autonomic instability, you might want to avoid tricyclic antidepressants or SNRIs, which can raise your heart rate or blood pressure. In individuals that have a lot of cognitive domain symptoms, you might want to avoid topiramate. In people who have a lot of fatigue, you might want to avoid sedating medications. So you want to consider those comorbidities when you're picking that preventive medication. So here's another patient. Erin, she's a 17-year-old female who hit her head to the ground 4 weeks ago. She had immediate symptoms that were present, but then her symptoms have continued to worsen over the last 4 weeks. Now she's got a continuous headache, continuously nauseous, she's dizzy, and she cannot sleep. She does have some risk factors for prolonged recovery, history of headache, history of anxiety, as well as a family history of headache, likely migraine, and a history of a prior concussion. But still, this doesn't set wrong with me. If you have a head injury, you worsen over time. Perhaps you stabilize and you don't get better. But why did you worsen it? So I have to dig a little deeper. And I say, well, what has she been doing since her concussion? I ask her. And she tells me, well, when I found a prior healthcare provider, they told me that if I had a concussion, I need to go to a dark room that's really, really quiet, really, really dark, and not text, and not stay on social media, and not talk to any of my friends, and not go to school, and previously very active person is unable to do any type of physical activity until I feel better. And eventually she keeps getting worse and worse and worse. This is called the dark closet effect. We need to not deprive individuals of life after they've had a concussion. We need a plan to return them to life in a graduated manner. We need to initiate symptom-limited both cognitive as well as physical activity so that we can avoid that dark closet effect. This is now actually backed up by evidence as well. This was a study in clinical pediatrics in 2015 where the control group was the group that initiated symptom-limited activity within a couple days. And the intervention group, so the group that they thought was going to do better, was the strict rest for 5 days. And interestingly, the results were surprising for the authors of the study. They found that the intervention group, the group that had strict rest for 5 days, were the individuals who did more poorly. They had a higher number of symptoms that were reported, and they had a slower symptom recovery. So now we know, through other data that has been published, that sub-symptom or sub-threshold aerobic exercise is actually a part of active rehabilitation and part of the recovery process. Dr. Letty's group has done a lot of research on this, looking at actually even cerebral blood flow abnormalities that normalize after sub-threshold aerobic activity. And recently, a randomized controlled trial using sub-threshold aerobic exercise demonstrating that the group that initiated that sub-threshold exercise are the individuals who had a faster recovery and lower symptom reporting. So you want to initiate symptom-limited activity. It is appropriate in cases to have 24 to max 72 hours of rest, but then after that, you want to initiate active rehabilitation, even in the presence of symptoms. You manage their symptoms, but you get them back into life, both cognitively and physically. And this sub-threshold exercise improves the recovery phase. But what is important when you're prescribing active rehabilitation is that you as a healthcare provider, as well as the athletic trainer that you might be working with, is very prescriptive about the active rehabilitation. You want to give them specific information regarding the intensity and the duration of the exercise because you don't want them to overdo it. If they overdo it, you end up taking a couple steps back. You want to be very prescriptive and monitor them on a very careful basis. In our Return to Play clinic, we see individuals back every week and sometimes even twice a week so that we can monitor their recovery. If there is a therapist or an athletic trainer involved in their care, we're able to space out our evaluations, but those individuals are monitoring them almost on an every other day basis to increase their level of activity slowly. So a slow, monitored progression of the level of physical activity is appropriate for active rehabilitation. So here's the case. The 15-year-old male hits in the head Friday night with immediate symptoms. They call an office after the injury and we say, okay, we'll see the kid on Monday in our Return to Play clinic. So the individual has resolution of symptoms by the office visit on Monday. The exam that I performed, yes, my neurologic exam is normal or at the baseline. So the kid writes, here's my mirror. I'm good at that. It was a hard hit, but I'm fine now. I got practice tonight. I got tournament tomorrow. Send me in. So what do? A, do I think, you know what? He didn't have a concussion, and he's not medically cleared to play. B, he did have a concussion, but he's fine now since he's medically cleared to play. Or C, he did have a concussion, and he is not yet medically cleared to play. The answer is C. The return to play decision starts with being symptom-free at rest, but it only starts there. The next thing is we need to initiate return to learn, because the majority of the individuals that I'm seeing are actually school athletes, and so they need to return to school first before they can return to their athletic activities. In addition, we then would initiate an exertion protocol to see if there was any unmasking of their concussion symptoms in the setting of exertion, and then we would initiate a sport-specific return to play protocol. You also want to obtain normal objective testing, not just our exam, but also look at their candidate tests. Compare their post-injury candidate test time to their baseline time to see if that is improved. You want to get objective vestibular testing and make sure that's returned to baseline or at least within normal limits. And the same thing applies to the cognitive testing, especially if you have a baseline that useful, but even if you don't have a baseline, you can determine if they're within normal limits based on their age and level of education. And then you initiate their specific return to play protocol, and then and only then do you consider a return to full practice and gameplay. Now, why do I say consider? Because before they go back in, you need to re-establish their baseline. In addition, you need to provide them with counseling. You need to talk to them about the fact that now they've had a concussion, and now they're at higher risk of having another concussion. And so you want to make sure that they're well educated before they enter, especially if they're going back into a high-risk contact sport. Now, when do you have to start having that discussion regarding retirement? Well, number one, like we talked about, if there's a reduced threshold for concussion, or less and less mechanical impact is now resulting in more and more severe symptoms, that's concerning. Because maybe after the next injury to the head, which might just be being grazed barely by an elbow or by a ball, that might be the concussion from which they are unable to recover from for a very long period of time or even forever. In addition, if there's permanent cognitive impairment, you would want to potentially recommend retirement from contact sports. With imaging abnormalities, as well as debilitating headaches that you've been unable to control. In these instances, you want to have the discussion about retirement from high-risk contact sports. So what are the take-home points? Number one, the goal of your pre-treatment assessment are going to be to obtain a baseline neurologic function. The goal of your second-line evaluation is to determine when the individual needs to be removed from play. We reviewed the key history and exam components of your office evaluation, as well as the concussion toolbox that may be available to you. And remember, the keys to management are twofold: symptomatic treatment, as well as preventing re-injury during the recovery phase. Excessive rest may not be beneficial. You want to initiate a symptom-limited return to learn, as well as return to physical activity after 24 to 72 hours of rest. And you want to use objective measures whenever possible to assess when they return to baseline and when they can return to play. And make sure you re-establish their baseline before you return them back into play. And also knowing when it is important to start having a discussion regarding retirement. Thank you.